record. And yeah, you should, I'll give you, make sure you have, hang on, I'll make sure you have access.
All good?
Yeah, you should be able to share your screen now.
All right.
If not, let me know. But I'll hand it over to you, Chris, and yeah, thanks for jumping on.
Just before I start, how many podiatrists here and how many physios?
We've got about 8 physios and got 5 podiatrists.
Okay, all right. Sure.
I'm not sure how many are on today, but it's about, that's normally the sort of ratio.
Okay, all right, no worries. Can you all see my screen?
Yep.
Yep, you can. All right, great. So thanks for that very kind introduction, Andrew. So as I said, my name is Chris Lee. I'm a sport and exercise medicine registrar. I will send this presentation through to Andrew, so you've got my contact details. Please feel free to email me or call me or text me if you've got any questions about anything. That's completely fine. Happy to take calls and emails. So just a little bit about myself. So I actually originally used to be an osteopath, so try not to hold that against me too much, but I am sort of familiar with what it's like to work in allied health. I trained at the Western Hospital. I started off as an emergency registrar, and then I started sports medicine training in 2018. As Andrew said, I've done a lot with junior football and senior football, both men's and women's, and treat a lot of track and field athletes as well. So I've just decided to have a bit of a chat today. I've got a couple of case presentations which will hopefully stimulate some discussion. I'm hoping it can be somewhat interactive, so if we can have some audience participation and feedback, that'd be great. I'm not sure how interesting I am to listen to, so an hour might be a long time, but we'll see how we go. And please feel free to interrupt me as I go, sorry. All right, so we'll start off with this case. So case 1, we've got a 14-year-old male who presents with proximal hamstring pain. And the injury basically happened, he was kicking a ball with his right leg. He felt an immediate pop in his buttock region. And he limped off the field, unable to run or walk normally. Now, Lyndon, you're top of my screen, so I'm going to pick on you. What are your thoughts? Just throw out some thoughts. What could this kid have done to himself, just really broadly speaking?
Might have a hamstring strain.
Mm-hmm.
Could have a bit of back neural pain. That's what comes on top of my head.
Yeah, good. So they're good 2 choices. Anything else you can think of?
Conjoint tendon.
Yeah. So he's 14.
Could have an avulsion there.
Yep, could have an avulsion injury. Good. All right. So yeah, they were good answers. The only other things I had in there were some atypical things like sort of an atypical SUFI, but most of those things you've got, that's fine. Okay. And we want to image this kid. What do we want to do? I know we haven't examined him, but just based on that history, he's got an acute injury, he heard a pop, he can't walk properly. Does he require any imaging, and if so, what? Anyone can answer. Any takers?
Depends on what kind of program he's in, Chris. Like if he stays in TAC Academy or something like that,
yeah,
they're obviously in a very different system. If he's just like a recreational, having a kick of the footy, yeah, it depends on, obviously with your TAC Cup and stuff, they'll usually send them off pretty quickly just to get a really good idea of return to play. But yeah. Okay,
all right, sure, that's all fine. Okay, so let's just have a look at, so I think if you've got a 14-year-old kid who's got an injury like this, I think he does need some imaging, irrespective of what level he's playing at. And I'll explain why in a second, but we'll just have a look at his x-ray. Now, who else can I pick on? Who are the physios amongst you? Is that Tegan? Is that you? Did you put your hand up? All right, do you want to just tell me what you're seeing on this x-ray? If anything, you can say it's normal if you want.
Yeah, I'm not great at looking at images, but something around sort of the neck of the femur on that side of the hip and the pelvis.
So left or right side?
Left.
Left side. Okay. All right.
This is left, isn't it? Yeah.
Sure. Yep.
Yeah.
So this is the left. Yep. And this is the right. Okay. All right. So we can see this is a skeletally immature individual. So he's got open growth plates. We can see them. Where's my cursor gone? We can see them here in the greater trochanter. We can see the femoral epiphysis as well, and we can here see the lesser trochanter. With this mechanism, so he's got right-sided buttock pain. Can we hone in on the right side and see anything that's slightly abnormal?
The neck of femur looks like retroverted. Like that.
Okay.
I forgot what that foramen is, but it looks smaller than the other side. I know it's covered.
The
on
obturator
left.
foramen, you mean? So in through here?
Yeah.
Okay.
Is that the issue? I forgot what it's called.
Yes, that's the obturator foramen. Yep.
Yeah.
Okay. All right.
Coverage look a little bit small on that.
Sure. Okay. So in terms of any gross pathology, does he have any gross hip joint pathology that we can see? Has he got a traumatic SUFI? Not obviously.
Growth plate doesn't look widened.
It doesn't look widened, and it looks pretty uniform around there. So it doesn't look too bad. Okay. So we're happy with that. There's no large, there's no large pathological fracture in the, the femoral neck or anything like that. Now, if we go back to our differentials before, so they included hamstring strain, apophyseal injury. Can we see anything around the ischial tuberosity of concern? So I'm not quite sure how well my X-ray is projecting up on the screen there. Can you see it properly?
Is there a bone fragment there? Like there's a little, yeah, that thing.
Yes, there is. Good, very good. So this is a little fragment off the ischial tuberosity. So this represents an apophyseal fracture. Okay, so the diagnosis with this has been an ischial tuberosity, apophyseal avulsion fracture. And that's why I said initially that I think it's important to X-ray all of these people because if they've got an avulsion fracture, you need to know a bit more about it. All right, so these are the pelvic apophyses. So essentially apophyses are secondary ossification centers with muscle attachments. Does anyone want to go through and name which muscles attached to these corresponding letters?
Iliacus.
Yeah.
Okay. So yep, iliacus attaches in. Iliacus probably goes more in through here. So right on the rim here. What else attaches here?
Obliques.
Yeah, good. So the obliques, good. Abdominal obliques, and then on the outer surface you also get some fibers from the gluteal muscles as well. Good. Over here, B.
Erect fem.
Okay, so rect fem is actually C, the AIIS. So what's up slightly higher than that?
Sartorius, I guess.
Yep, so sartorius and TFL has some fibers attaching there, very good. So yep, so C is the direct head of rect fem. D.
Rectus abdominis.
Good, so rectus abdominis at the top and then more inferiorly the adductor muscles. And then E.
Adductors.
Yeah, so adductor magnus.
Adductor mag.
Is attached to E and also hamstrings. F.
Iliopsoas.
Yep, iliopsoas, very good. And they've left off G for some reason. Over here, what attaches over here?
Glute med.
Glute med and glute med. Yep. All right. So that's another little diagram, just showing exactly which muscles attach to what spot. All right. So pelvic apophysis. So what is an apophysis? It's essentially it's the location of a growth plate with a muscle attachment. Now, radiographically, these will appear once they're ossified. And that usually occurs after the age of around 12 to 13. So if you X-ray a kid with a suspected apophyseal injury before that, you probably won't see anything, and that's important to note. So there's essentially two types of injuries we can get for apophyses. We can get apophysitis, which is inflammation of the apophysis, as the name suggests, and that's normally from overuse. The symptoms are normally gradual and onset. If you X-ray these, they may be normal, or they may have a slightly fluffy or irregular appearance. And the most common one you guys will probably see will be Osgood-Schlatter around the knee. And then we've got apophyseal avulsion fracture. So this is an abrupt onset of pain following either a rapid concentric or eccentric load. Now, they're seem to be more common in males than females. And I think that's generally because at the start of puberty, males will start to developing a higher amount of muscle mass, so there's more force on the actual growth plate. And these are usually seen on X-ray, but only if ossification has occurred. So if they're below that sort of 12-year-old category and you're suspicious of an avulsion fracture because there's been an abrupt onset of pain at one of these sites, then an MRI might be the most indicated scan if you're concerned. So in terms of which ones are most commonly injured, it really depends on what source you read. But essentially the ones up in bold there are the most commonly injured ones. So the ischial tuberosity, the AIIS and the ASIS. And the 4 down the bottom are far less commonly injured. So like most things in sort of musculoskeletal medicine, we can manage things conservatively or we can manage them surgically. So does anyone have an idea in their head as to which ones we can manage conservatively and which ones need surgical intervention? Okay, so very briefly speaking, most of them can be managed conservatively. The exact protocols for managing them conservatively are, they're quite vague, but essentially, protected weight bearing for a period of sort of 2 or so weeks, potentially more depending on pain, and then 4 weeks of weight bearing is tolerated with a gradual return to activity from somewhere around 6 to 8 weeks. There have been some more aggressive protocols put in place where, especially for an ASIS or an AIIS, the hips, there's bed rest and fixed hip flexion for 2 weeks, but I think that's quite difficult with a young kid. And then there's surgical intervention, which is usually indicated for displacement greater than 2 centimeters. So if we go back to our initial X-ray of our 14-year-old kid, and we go back to his little area of his apophyseal avulsion here, so I've measured it out for you. It's about 9.6 millimeters, so it's just under a centimeter. So does anyone feel strongly about managing this conservatively, or does anyone feel strongly about getting a surgical referral and opinion for this? So if this patient's in your rooms, what are you going to do with this chap?
I'd probably send him to you and let you make the decision, to be fair.
Okay, fair enough.
Yeah, same here.
Sure. Okay, no worries. So, I mean, if we go by most things you read, less than two centimeters is usually okay for conservative management. So this kid was actually managed conservatively. Now, I didn't treat this kid. This kid was treated at the public hospital, and he was managed conservatively. So the first time I saw this kid was, oh, so I've gone through that already, sorry. The first time I saw this kid was about 14 months later. So he walked into my office, he's now 16. He's got ongoing buttock pain. He's got the inability to kick and inability to sprint. So I tried to get a history of what happened with the initial injury. So he did the injury. It sounds like he did some form of physio for about 6 weeks. I'm not quite sure what his compliance was like. It sounded like mainly stretching rather than loading. He got back to playing basketball over summer where he had some awareness, but he was still able to play. But then he'd restarted football training recently, and he was really struggling. The coach was noticing he was moping around the field, just couldn't get up any speed, couldn't kick and couldn't accelerate or couldn't sprint. Any thoughts as to what's going on with this kid?
Hasn't repaired.
Hasn't repaired, is that what I heard?
Yeah.
Yeah, so non-union. Is that basically what you're saying? It's non-union. Yeah. Okay. All right. So, what kind of imaging might be helpful in this instance now? What do you think we can do with this kid to sort of figure out what's happened?
Maybe MR or CT?
Yeah, MR would be really good. So CT also would be helpful, but just keeping in mind he's 16, we probably want to avoid irradiating his pelvis if we can help it. But that certainly would give us some information. So,
Chris, sorry, question.
Yep.
Why wouldn't you re-X-ray?
We did. We re-X-rayed. What can we see here?
Big bits come off.
Yeah, so he's that little fragment, which was sitting about here, has now ossified, and he's got this huge ossified fragment of bone sitting underneath his ischial tuberosity, and it's a non-union with the rest of the bone. So this isn't ideal. So I'll have a look now at his MRI, which I'll try and, I'm not sure if you can make sense of these images very well. So basically we've got some axial slices through here, and I'll just move this. So this is the left side, this is the right side. So this injury's basically done two things. It's caused a big bit of bone fragments to come off the ischial tuberosity, and then there's now fibrous union between the fragments and the ischial tuberosity, which is basically floating around in the wind. And because of it's actually, it's approximated towards the femur. So now he's got this ischiofemoral impingement as well. So this is a normal ischiofemoral space on the left side. And then this is the ischiofemoral space on the right side. So you can see it's markedly narrowed, and there's increased fluid signal. So there's edema in through here. And this is the messy bit of bone. And I'll just, what I'll do is, I'll see if I can get out of this for a second and just flick through his actual MRI images to give you a better look. So can you guys see this? Yeah, okay. So this is the left, this is the right. If we flick through, this here is his ischial tuberosity, and this is the normal side. So this now here is the bone fragment, which is ossified. This is the fibrous tissue attached between the two. And then this is his hamstring tendon coming in through here. And we can see there's increased signal on that as well. So he's got this quite tendinopathic proximal hamstring tendon. He's got this edematous bone fragment coming off his ischial tuberosity, and he's got this fibrous tissue in through here. And then he's got this ischiofemoral impingement coming in the inside through here. So he's also got, as we can see here, marked gluteal atrophy on this right side compared to the left. So this was a bit of a disaster. This kid had quite significant anatomical structural issues going on in his pelvis and his hip, which was quite difficult to manage. So yeah, to put it bluntly, this was a bad outcome. We did manage to, I did rehab him for about sort of 3 months. He did manage to get to a period where he could run relatively pain-free, but kicking was still a problem for him. It was a bit difficult to tell with him how much of his pain was the ischiofemoral impingement or the hamstring tendon, but I think it was probably still a combination of both. And I did end up referring him for a surgical opinion, and he was sort of lost to contact after that. So I don't actually know what happened to him. But basically, the take-home message with this is that if you suspect in any way, shape, or form that there could be an apophyseal fracture, you should X-ray the patient, because you're not going to know unless you X-ray them. Kids don't tend to get muscle strains until they're skeletally mature. The apophysis is actually a weaker point than the muscle or the tendon, so they're much more likely to actually sustain an apophyseal fracture rather than a muscle strain. So with a kid, especially if it's a proximal hamstring or around the site of an attachment, I think it's important to always X-ray these kids, because if they have got displaced fractures, they can cause issues. And every case is nuanced. So as we saw with that kid before, if we actually go back to his initial X-ray, his displacement was only, was it less than a centimetre. I'm not quite sure whether he had a poor compliance with the rehab and he had a secondary injury, but it looks like on the second image, he's probably displaced by about just over 1.5 centimetres. But it's also, the little fragment has lateralized a little bit. So it's also causing that ischiofemoral impingement, which is an issue. So even though the recommendations are less than 2 centimetres, every case is individual. And if you're not sure, it is always best to just handball on someone else to make that decision. Some studies have shown that there should be a lower cutoff for the ischial tuberosity, which should be less than 15 millimetres displacement, because there is a doubly risk increase of pseudoarthrosis and non-union if there's greater than 15 millimetres displacement. But as we saw with that kid, his was about a centimetre and he still had a bad outcome. But as someone also mentioned before, the demand of the athlete's also going to depend, and the level of activity they're playing in will also depend on what you do with them. All right, any questions with that kid in that case? No, okay.
So Chris, if you were seeing that guy privately, What would you have done differently? Would you just have seen him every couple of weeks and monitor that he was improving?
Look, that's a really good question. I don't think I can necessarily criticize what happened with the initial management, because, you know, if you go and look up all the guidelines for these injuries, you know, less than 1.5 centimeters for a hamstring avulsion is considered acceptable. I suppose where I'm going with this is that they can get complicated, and the decision isn't always as black and white as these the guidelines follow them. It is quite nuanced. I think the fact that that little fragment was displaced laterally would make me think that maybe a surgical opinion would be warranted earlier. If it had just been an inferior displacement, potentially it may not have caused so many issues, even if it was a non-union. But I think that ischiofemoral impingement, because the fragments moved to the side, was causing a lot of issues. And I'm not sure how much ischiofemoral impingement you guys have seen, but it's often quite tricky to treat. But yeah, I would have followed him up closer. I probably would have done some repeat imaging with him as well, just to make sure it was actually healing. But you know, sometimes it's really hard to tell which ones are going to be non-unions. So it can be really tricky. And that was just a bad outcome of a kid who I think most people, based on the initial x-ray, probably would have managed conservatively, unless you're a really interventional surgeon who fixes everything. So the bottom line is it's just complicated.
And do you think there was anything in particular that could have caused it to displace more and ossify? Like, could he have been doing a stretching protocol that was pulling it further?
Yeah, very, very, very much so. So I think, I don't know what rehab he was really doing. I tend to find when patients come and see me and you ask them what they did for rehab, they generally can't tell you very well.
Yep.
They usually confuse stretching for strengthening, or they use them interchangeably. So it was really difficult for me to get a clear idea of exactly what he was doing. I suspect it was more stretching, because when he showed me the few of the things he was doing, it seemed to be more stretching. So I wonder whether that was part of the issue, is that he was stretching and it just caused it to displace further. But I'm not sure. I don't know whether maybe he returned to basketball too early and maybe he sprinted and had another injury which just displaced it and pulled it out. I'm not sure, unfortunately. There was a bit about a 14-month gap between when he had the injury and when I saw him, so I'm not sure.
Hey Chris, when you saw this patient, did you feel that there was any, from a rehab viewpoint, any contraindication or consideration with regards to eccentric loading or plyometric loading? Yeah,
so eccentric load was the last thing I tried to add in, because he just didn't tolerate it at all. I just had to get his glutes activated first. He had absolutely zero gluteal activation, so he was just basically yanking on that hamstring tendon, which was already, as we could see, under increased load, because it was sort of had two attachments essentially. So we got his gluteal muscles activated. We got his external rotators activated. We got him doing some more sort of more concentric load first, like some gluteal bridges with his foot up on a bench. Once his glutes were activated, to get some load under the tendon, and he tolerated that fine. He was running fine. It was just anytime we got him into an RDL type position, he still felt it pinch. But you know, you guys probably know better than I do. It is often difficult rehabbing kids who haven't stopped growing yet, because they've just got very poor body awareness. So getting a 16-year-old kid to do arabesques and single leg RDLs is often quite tricky, because they just don't have the balance and coordination to do them properly. So it was quite challenging rehabbing this kid.
And did you think that because of the relative, I mean, there's definitely more of a retroverted look to his right, I think it was his right side, on the x-ray.
Yeah.
I mean, that's not something you can necessarily change structurally, but did you feel that was a big factor working against him in terms of the ischiofemoral impingement?
Probably minimally, because it wasn't significant on the other side. I don't think his hips look too bad from this point of view here. So I think it was just, we can see, you know, if his hamstrings are touching here, he's got all this space, but his hamstrings are now touching here. So I think irrespective of the orientation of his hip, I think this is always going to be difficult to manage.
And that change you saw only occurred over what, 18 months, 24 months?
It was in 14 months. So that's the thing with an apophysis, is that it will continue to ossify because it's a growth center, secondary ossification center. It'll continue to grow. And that's one of the problems. If they do get displaced, they can form a big bony fragment somewhere.
Good one.
All right, any other questions with this one?
And there's no surgical intervention for that now that it's ossified, is there?
Well, there is. So I did discuss with a couple of surgeons, and it was very much try not to do anything, but if you need to do something, we will do it. And then basically have to debride away all the scar tissue between the fragment and the ischial tuberosity, reapproximate it, and then basically drill and screw into it. So it's a bit of a big deal. You know, you've got your sciatic nerve running down through here as well, which is vulnerable. So it's certainly not without risk. And you just have to have very clear conversations with the patient about the risks versus the benefits and what their long-term athletic goals were. This kid was very much a recreational kid who just played football with his friends on the weekend. He was never going to be an elite athlete. So I think if he was symptom-free with his ADLs, he could run around and play basketball and do what he wanted to. It was probably best to leave it. But if it was a higher-end athlete who was looking to, who was playing TAC Cup or wants to get drafted, I think that you'd really have to reconsider this. I don't think that's really compatible with a sport like football with repetitive kicking. But the other thing is that, fixing this in the public system versus privately is also going to be quite different. All right, so let's move on to case 2. Oh, hang on a second. So I've got my kids walking in the room here. No, they haven't. All right, case 2. So we've got a 20-year-old male who's got sudden onset of lateral hip pain while pivoting off his left leg playing football. He's collapsed on the field, unable to weight bear, and he's taken to emergency by ambulance. Now, as what happens in emergency departments, anyone with an injury gets x-rayed. So does anyone want to comment on whether they can see anything on this x-ray? I apologize, this x-ray is probably even worse quality than the first because it was a photo from my phone.
What's going on with his right neck of femur there? Is that just me seeing something that's not there?
Through here?
Yeah, that little white sort of line there.
Yeah, so I think this is just the rotational.
Just the imaging. Yeah.
Yeah. So the cortical margins are still fine. That's just the back of his greater trochanter just sitting behind the femoral neck there.
Yeah. Okay.
So his symptoms are on the left side. Okay, so if you can't see anything, that's completely fine because I can't really see much either. So there's nothing really obvious on here. He hasn't snapped through the neck of his femur. From this view, at least, his hip looks end-located, although a lateral would be helpful just to make sure he hasn't dislocated his hip. He hasn't got any irregularity over the greater trochanter. Doesn't seem to have avulsed anything else. There's no gross bony abnormality that we can see. So any thoughts? Any thoughts on why this kid with a relatively normal x-ray has collapsed and can't weight bear on his left leg with lateral hip pain? So what might be causing this injury?
Could be lumbar related. I guess I'll say avulsion because of the last case. Labrum can sometimes be felt in the lateral hip if there's an acute labral tear.
Yep, good. All right, so that's pretty much what I had. So acute labral tears can do these. Gluteal muscle strains can do these. Always put pathological fracture if someone just collapses and they can't move. Lumbar spine referral, and then as you mentioned before, could this also be an apophyseal injury or a avulsion injury? So this is MRI. Now, I don't know how often you guys look at MRIs. So this is a fat suppressed image. So anything that's fluid will appear white. And this is essentially where he's sore. So this is his ilium, and then this is his glute medius and minimus, and these are his obliques coming in through here. So there's all this fluid signal tracking around the iliac crest, coming down to the gluteus medius and minimus, and also up around here with the oblique and abdominal muscle insertions. So this is an iliac crest apophyseal avulsion. So if we go back to our list of pelvic apophyses, it's kind of important to know when they ossify and when they fuse, because you can't see something that hasn't ossified. So if you X-ray them, you won't see it, but the apophysis is vulnerable to injury until it's completely fused. Now, depending on what you read, you'll get slightly different numbers, but generally with the iliac crest, it'll begin to ossify around 13 to 15. But complete fusion may not occur until about the ages of 18 in females and 20 in boys. Now, we often forget about this is because these athletes are usually competing in adult sport. So this was a VFL guy. And we often don't think about these adolescent developmental injuries or pediatric injuries in what we consider adults. So it's important to remember that these don't completely ossify until a little bit later in the 20s. So this was what this boy underwent. He had a iliac crest avulsion. So the iliac crest, it normally starts to ossify around 13 to 15. It'll start anteriorly and will extend its way posteriorly, but you can get a bit of a fragmented appearance where there's little gaps in between. The iliac crest is also used for Rissa staging, which is basically a sign of bone maturity. Now, apparently the ischial tuberosity does actually completely fuse later, but it's very difficult to see, so it's not used and not very helpful. But as you can see, if a child has an injury which you suspect is a apophyseal avulsion and they're younger than the age when it's ossified, you're not going to see it on an X-ray. So if the X-ray is normal and you're worried, you need to get some further imaging. So just a bit more of a brief summary. In terms of who injures what, generally younger teenagers will injure the AIS and the ischial tuberosity, and the older athletes will injure the ASIS and the iliac crest. So this kid was, he was managed conservatively. He actually, the diagnosis, he was discharged from hospital without a diagnosis. We had to MRI him to get that diagnosis because it wasn't immediately obvious on the X-ray. And he was protected weight bearing for about 2 or 3 weeks, and then he managed to successfully return to football the following season. So basically the take-home message with this one is that these injuries can occur in athletes in their early 20s. So you have to remember these as well. They're not just injuries that happen to kids, especially around the iliac crest. And that's all I had for today. Any questions with that second case?
Chris, what was the mechanism again?
So basically he was just pivoting off his left leg. So just going to change direction. And there was just a big contraction of his glute med and his obliques, and he just collapsed. His leg gave way on him and he couldn't get off the floor. So I got a call from the physio because I wasn't at the game that day. They thought he had dislocated his hip because he just couldn't weight bear. He couldn't move his leg. He was in agony. So he got carried off in a stretcher. So these are uncommon injuries. I suppose the only thing to mention with this kid as well is that he did have a history of, he did have some iliac crest apophysitis leading up to this injury. And he had a cortisone injection around that area a couple of weeks beforehand, which may have weakened the area. So whether he would have actually avulsed that or not without the cortisone, I'm not sure.
Do you often expect that if they've had some apophysitis that they are more likely to have an avulsion?
Yeah, that's a good question. They certainly can avulse if they've got some apophysitis, but often if they've got some apophysitis, it'll limit what they're doing. So they actually won't load the area as much. These injuries are also very common in kids with no apophysitis. They just have a sudden forceful movement and they just rip it off the bone. So sometimes I find that having some apophysitis is somewhat protective. Unless you inject them with cortisone, mask the pain and weaken the area.
Has any of the physios seen any of these? Seen one of these?
Not on the iliac crest, I haven't.
No, look, they're not common injuries. I've only seen one. I've seen quite a few iliac crest apophysitis, but I've only ever seen one actual avulsion.
We had one in the NBL about 10 years ago. And yeah, it was misdiagnosed, like the head physio it was misdiagnosed.
Apophysitis or a fracture?
An actual fracture, so an avulsion. So it was a young development player. So he was like 18 or 19.
Yep.
And yeah, it was hamstring tendinopathy, you know, not hamstring, sorry, hip flexor tendinopathy, you know, iliopsoas. There was lots of diagnoses being thrown around.
Yep.
And he went through about 3 different types of imaging before they found it.
Oh, wow. Okay.
Yeah, it took a long time for them to get it. Yeah.
Yeah. I mean, they're really not common injuries, so they're not the first thing that comes to mind, especially if the patient's presenting with a bit of a vague history or a vague presentation of pain. It may not be the first thing that you think of.
Well, there wasn't a specific mechanism of injury either, so they think it might have been like a stress reaction that had then like developed. Right. So, you know, for a long time it was being treated like a classic, you know, iliopsoas tendinopathy or you know, something like that. And yeah, and it wasn't until I think they ended up doing they did like an initial MRI and something didn't come back right. Like they ended up having to do it twice before they got enough imaging to sort of
to diagnose it.
That.
Yeah, well, okay.
And he was non-weight bearing for like 6 weeks, I reckon. Yeah. For quite some time.
Wow. Okay.
Yeah.
Well, yeah, look, I mean, if you need 2 MRIs to diagnose it, it's obviously a complex injury.
Yeah, well, I think the first one just didn't have like it must have been the imaging location or whatever. Like they obviously just didn't look at the right area or whatever.
Oh, right, okay.
I wasn't involved in that process because the team doctor was doing a lot of it. But yeah, so yeah, but I think they just didn't get enough information from the first MRI, so they ended up doing a repeat one maybe in a few weeks.
Right. Okay. Sure. Yeah, they probably honed in on something else. Gotcha.
Yeah.
Yeah. Okay. Any other questions about this case, or the first case, or anything else vaguely related to this? Apologise to the podiatrists in the room who probably don't see a lot of pelvic stuff, but I suppose you'd see a lot of sort of similar things in the foot.
Yeah, obviously calcaneal apophysitis is one that we deal with a lot.
Yeah.
So Chris, you probably mentioned this. So would you be imaging any proximal muscle-based injury that has an acute mechanism then in an adolescent?
Look, yeah, if the story sounds like an acute injury and it sounds like it's somewhere around the pelvis, I would image that. Yeah. Just because, I think you don't want to miss an apophyseal injury. Just because if they are displaced, then occasionally they do need surgical intervention or a slightly different return to play protocol than a muscle injury. And I think that with this age group, they don't tend to the weakest point is actually the apophysis rather than the muscle or the muscular tendinous junction. So they're actually more likely to injure those parts. So I would recommend imaging anyone who had an acute injury like this.
Yeah.
And did you say your general rule of thumb was X-ray if they're greater than 12 years of age and MRI if they're younger than 12?
Yeah, I think an X-ray is fine because, it's hard. I've seen a couple which I have MRI because they were young and I still X-rayed them if they were sort of 11 or 12. If they're any younger, do X-ray them is a good point. I think if they're any younger, I still would X-ray them because there's other things you'll pick up on the X-ray, like pathological fractures or bone tumors or things like that, which kids unfortunately do get, and you don't really want them to be waiting for a week or two with that going on, where you may be waiting for an MRI when you may have seen it on an X-ray. So I think any acute injury where a kid can't weight bear, they need an X-ray.
Yeah.
Adam, do you guys get bulk building rights for pelvic X-rays? You don't, right?
No.
Okay.
That was going to be my question, Chris. It's like say patient walks in the clinic and we're suspecting of something like this, what would be your sort of like to involve imaging? Would it be a case of getting you involved and saying, look, I'm suspicious of this, what do you think?
Yeah, absolutely. I mean, you can just give me a call, and if it sounds like that, I can just write up an X-ray referral. We can get it done like that. Or if it's too difficult to get in contact with me, you can send them to the GP requesting an X-ray. If you're really worried about them because they actually can't wait there, I don't think it's unreasonable to send them to the emergency department to get some imaging done. But you know, they may be waiting hours, obviously. But if you're really worried, that's certainly an option for you. At least you're covering all bases with that. But yeah, I'm certainly happy to be called if you think someone needs some imaging, and we can organise like that.
Great. Does anyone else have any general questions for Chris? No? All right. Well, thanks so much, Chris, for coming and having a bit of a chat.
That's okay.
As I said, for those who jumped on a little bit later, Chris is going to be starting to work with us from next year. So it's going to be really great to have someone of his calibre involved with the clinic and be able to obviously discuss cases, complex cases like this, and get them perhaps scanned and imaged earlier, so we can obviously get on top of it and get these people recovering as quickly as possible. So yeah, super excited about that. I think it's going to be really great to ongoing for these sorts of things as well. So do you have anything else you wanted to add, Chris?
Oh, I was just going to say, the only other thing was, if you're going to refer me a patient and you think they need imaging, just let me know beforehand that they need imaging, so I can organise the imaging before they see me. It just makes things a bit easier, especially things like knee MRIs and stuff like that. If you're worried someone's done a nice image to their knee, just let me know. I'll get the imaging and then they can send me afterwards, rather than double handling things. Even with X-rays as well, that's fine.
Yeah, cool.
So Chris, as a registrar, are your MRI rights the same as a sports physician, or are there certain things in terms of bulk billing?
Yeah, it's a really good question. So they're different, unfortunately. So I fall under a GP category for MRI rebates. So knees, I can get bulk billed. Cervical spines, if it's queer radiculopathy, I can get bulk billed. Spines for kids. Brain, if there's consideration of intracranial pathology. So there's a couple of indications where I can get them bulk billed and a couple where I can't, which is a bit frustrating. That's a good question.
Can I also ask you a non-clinical question, Chris?
Sure.
And pardon my ignorance for this question, because I get asked this all the time from patients.
Yep.
With your background, what do you see as the major differences, or what's the philosophy between osteopath and physio?
Oh God, right, okay. How long have you got? So yeah, it's a good question. I think that the two can sometimes end up doing very similar things. I think my understanding of traditionally osteopaths see things in a very structural way. So they've kind of got these, they've got these sort of 4 principles of osteopathy, and one of them is structure and function interrelated. But that seems to be a one-way kind of mantra, where structure and function interrelated, but function and structure don't seem to be. So they sort of believe that if everything's structurally in line, it'll start to work better. So they tend to, look for asymmetries in where people, people's bodies are sitting, and work on that and try and get them sitting symmetrically for their function to improve, which, which can certainly happen. But there was never traditionally a strong basis on emphasis on rehab. That's changing. I think all the old school osteopaths are still seeing things purely on a structural point of view and ignoring function, but most of the newer graduates aren't doing that, and they are dabbling in rehab. And some of them are quite good at it. They've done extra studies in rehab, but generally they're not as good because it's not really the primary focus at uni. So my understanding of physio is that the emphasis is probably heavier on functional rehab rather than purely anatomical structural. But again, that's probably very, a gross oversimplification of what physios do. So basically, I think it comes down heavily down to the practitioner. Some osteos will get very caught up in their dogma about this is what osteopaths do, this is what osteopaths don't do, and others will say, I'm going to do what works and what's evidence-based, and that will be X, Y, and Z depending on what's presented to me. So that's as politically correct, I think, as I can put things. But it's probably going to come down to the practitioner rather than the profession.
Thank you.
Does that help at all?
Sure.
Yeah, that was great.
Okay, good.
I've just got one question on MRIing a child.
Yeah.
Just in terms of, obviously kids have different personalities, but say you've got a kid that's quite a worried and nervous kid, and you're putting it in an MRI where they've got to sit still for a number of, half an hour or however it is. What's sort of your protocol with, do you, like for us, should we refer to someone who can sort of undertake that, role of maybe sedation, or what do you sort of?
Yeah, that's a really good point. You've got to really suss out the kid in front of you, and you've got to speak to the parents to find out whether you think they will actually be able to tolerate lying still for 30 minutes. And a lot of kids won't. And I think, ultrasound does have a role. You can, see bits and pieces on ultrasound that you can't see on X-ray if things aren't radio opaque. So I think if you're at all worried about the kid's ability to be sedated, then I think, don't try and do an MRI because they're awfully expensive. And then if it fails, you sort of, what do you do from there? So I'd probably go with an ultrasound if you're worried, which may or may not give you the information you're after. If you have to sedate a kid, you're probably going to have to send them somewhere like the children's where they're used to sedate kids. To be honest with you, I've actually never had to do it. I've never had to sedate a kid for an MRI or order an image on a kid which hasn't been able to lie still. But I don't think I've actually done an MRI on a kid under the age of 13. So I'm sure it does happen, but it would be something to discuss with the radiologists at the facilities to find out what their process normally is. I don't like sedating kids. It's a big deal. So if you can avoid doing it, you do. So it's a bit of a last resort, but if you have to, you have to. You just got to find a way of doing it.
Okay, cool.
Awesome. All right. Well, thanks again so much for jumping on, Chris.
Not a problem.
We look forward to sort of introducing you to the team a bit more properly once we can, hopefully in the next few weeks.
Cool.
But yeah, thanks everyone else for joining in, and I'll make this recording available on the hub if that's okay, Chris.
Yeah, that's fine. Not a problem.
Awesome. Yeah, excellent. All right. Well, enjoy the rest of the afternoon, guys, and thanks again.
All right. Thanks for having me, guys. See you later.
Thanks, Chris.
Thanks, Chris. All right.